Hello. Thank you for participating today in this activity. I will be reviewing for you allergic rhinitis, the burden of disease. In many ways, this program is a combined perspective from both the physician and the patient, and you'll see that in the data we review throughout this program. We developed this in collaboration with National Jewish Health, Integrity, and it was supported by Teva Respiratory. On this slide, you see my disclosure. I serve on the Teva Advisory Board. We hope to cover today the following objectives: recognize and differentiate allergic rhinitis symptoms from other common disorders, formulate management plans for patients with AR according to available evidence, describe the characteristics of available therapeutic options for patients with AR, and implement strategies to improve treatment adherence. Let me begin with the nature of allergic rhinitis. Allergic patients generally have early onset of disease, but it's important to realize that we do see adult onset allergic rhinitis, so the fact that it's developed later in life does not obviate the fact that it may still be allergic in nature. The family history is important. As we know, atopic disease runs in families, so there's greater incidence in those that have a past history in their families of underlying allergic disease. The symptoms, the frequency is important. Is it seasonal? Is it perennial? What happens after certain exposures, such as animals? Is it worse indoors, outdoors? All of these factors contribute to identifying the underlying triggers and potentially the correct diagnosis. What happens around chemicals, environmental tobacco smoke, since these are not primarily allergic triggers? What about the types of non-allergic disease, so non-IgE mediated disease? These are the common stratifications. Vasomotor rhinitis being the most common. This is a vascular instability in the nose that causes very similar symptoms to allergic rhinitis: runny nose, congestion. Infectious rhinitis. NARI stands for non-allergic rhinitis with eosinophilia. So these are individuals that have rhinitis, that have presence of eosinophils in their nasal secretions, but their skin tests negative. Occupational rhinitis, sometimes we do a poor job querying for this, but individuals up to the order of 20% may have an occupational trigger. Hormonal rhinitis, particularly in the elderly, where there may be subclinical hypothyroidism or other hormonal imbalances. Drug-induced rhinitis, as we see more polypharmacy these days, we need to consider a drug-induced etiology. Atrophic rhinitis, and then other systemic processes such as Wagner's or other vasculitides. One may have limited Wagner's that's isolated to the upper respiratory tract, and a variety of other systemic disorders that may have rhinitis as a contributing factor. Here we see the risk factors for allergic rhinitis. As mentioned, family history of atopy. In epidemiologic studies, we see higher socioeconomic class serving as a risk factor. And then there are unknown influences and their impacts, such as infections, animals, and environmental tobacco smoke. We always see a report of serum IgE levels above 100. This came from a 1989 publication in the New England Journal of Medicine by Ben Burrows, where they stratified various levels of IgE and the risk of allergic disease. And a 100 was the best cutoff. Realize, though, there's a lot of overlap. We see individuals with higher IgEs, 300, 400, that don't manifest much of clinical symptoms of AR. On the other hand, we see individuals with IgEs of 70, 60 that have significant underlying AR. So it's not a great screening test, but nevertheless, as the IgE goes up, the risk increases. And then the last bullet is extremely important: the presence of positive allergy skin tests. The definition of allergic rhinitis is frequently stratified as seasonal and perennial. Seasonal allergic rhinitis is caused by IgE directed against seasonal allergens, such as tree pollen, grass pollen, weed pollen as examples. The length of seasonal exposure on these allergens is dependent, obviously, on the geographic location, climatic conditions, and other environmental factors. For perennial allergic rhinitis, we define by IgE sensitization to perennial allergens, dust mite being the most prevalent, particularly in humid environments. The mite needs approximately 50% relative humidity to survive. Other perennial allergens include animal danders, cat, dog, again, being very common. General considerations for AR. Although the terms seasonal and perennial are clinically useful, they're useful in research studies, they're not always the most pragmatic. For example, somebody may just have symptoms if they go to a family member's house that has a cat or a dog and their cat or dog sensitized. In that individual, the symptoms may only last a couple of weeks or the time or duration of the exposure. It's still a perennial allergen, but really what's more important is the frequency of those symptoms, the duration of those symptoms, and the severity. That is what is going to ultimately drive our therapeutic decisions. Let me transition now to the burden of AR. AR symptoms are self-reported in approximately 90 million people. This is the most common chronic disease. 1 in 5 individuals is impacted by allergic rhinitis. Frequently, it's underestimated from the standpoint of morbidity. However, it has a huge quality of life impact. When we look at physician-diagnosed AR, approximately 70 million people. As mentioned previously, 80% of patients with AR develop their disease under the age of 20. However, 20% develop it in adulthood. AR increases steadily from age 4 to age 18 and is more common in boys in those early years. And when we look from a practice burden standpoint, PCPs estimate that 27% of their patients ages 4 to 17 years had AR, while ENTs estimated up to 44%. Quite a significant socioeconomic burden. You're going to see throughout this talk 2 surveys. One was completed in 2006, referred to as Allergies in America, and then this same strategy or design was implemented again in 2010 in the nasal survey to try to gauge the change in the epidemiology of allergic rhinitis and non-allergic rhinitis compared to a control group. Obviously, today I'm not going to show you all the questions that were interrogated through the survey, but throughout this talk, we'll use some of the representative questions. Here on this slide, you see the following question. Adults with nasal allergies who reported being frequently or sometimes limited in the following due to their health versus adults without nasal allergies who reported being frequently or sometimes limited in the following due to their health. And what we see on the left side of the graph are the outcomes: not doing well, limited in social activities, limited in having or playing with pets, outdoor activities limited. And the basic message here is you see almost a doubling of the impact on the quality of life in those that have underlying allergic disease versus those that are non-allergic. Now looking at the short-term duration, the question was adults with nasal allergies who reported being extremely or moderately troubled in the past week due to nasal allergies versus adults without allergies. And again, now we look at a short-term outcome such as sleep, lack of good night's sleep, waking up during the night, and difficulty getting to sleep. You see almost a 3-fold increase in those with underlying allergic disease versus the controls. This is a side-by-side comparison of the 2 surveys I alluded to, the Allergies in America in 2006 and the nasal survey in 2010, and you do not see a major shift over those years in the underlying impact or burden of AR. What about factors that affect the care of patients with AR in the real world? That's what really matters. Proper assessment of nasal symptoms and differential diagnosis. I can't stress that enough. That's a lot of what we do at National Jewish Health. You folks send us patients. We do intensive evaluations in an effort, hopefully, to tailor therapy. Adherence to clinical practice guidelines is very important, so we're practicing evidence-based medicine, selection of appropriate therapy, and as in many disease areas, adherence being extremely important and the education associated around that. There are also barriers we have to overcome. For example, patients' refusal to adapt environmental precautions or change, control of allergens in the immediate environment, and providing patient education. Let me transition now to the assessment and diagnosis of AR using the guidelines. Effective evaluation determines you need to know the pattern, the chronicity of disease, and seasonality. Response to medications is exceedingly important. Most patients just come in and say, I've tried everything. We need to know in what combination have they tried these medications, how long have they tried them. For example, corticosteroids, 1 to 2 days is not a therapeutic window. As many of you know, the anti-inflammatory effect takes quite a bit longer. The presence of comorbidities. If we don't address those, we're never going to get the underlying symptoms and allergic disease under control. Detailed environmental history is exceedingly important. We've had numerous patients where they've had insidious mold exposure, leading to underlying hypersensitivity pneumonitis and other comorbid associated diseases that went unrecognized. And then including a very important measure, the quality of life. We need to do a QOL assessment for nasal and non-nasal symptoms in regards to severity. The physical exam, here on the slide you see some of the common manifestations. For non-nasal symptoms, people get ocular allergic conjunctivitis, clear watery discharge. In the ears, there may be possibility of underlying associated otitis media. The nose, obviously, you see swollen, pale, boggy turbinates. Posterior pharynx, you may see cobblestoning. There may be sinus tenderness to palpation, but that's not an overly sensitive marker. Additional symptom assessments include throat symptoms, chronic cough. We'll come back to this, but a large percentage of patients with underlying allergic rhinitis may also have lower respiratory tract involvement in the form of obstructive lung disease. Need to query for headaches, mental health, and global QOL assessment. Further testing and evaluation includes the following. If we're going to differentiate allergic from non-allergic rhinitis, we first need to demonstrate the presence of allergen-specific IgE, and this is frequently done via skin testing. However, if you don't have skin testing available, in vitro RAS testing is an option. We also perform fiber optic rhinoscopy, looking for mechanical issues that may be contributing to the underlying nasal symptoms. And then the rest of the items on the list occur less frequently, such as nasal provocation testing. I should stress, however, many of these patients that are obstructed in their respiratory tree frequently have underlying obstructive sleep apnea, and one should query for daytime sleepiness, snoring, AM headaches. Those all may be clues to potentially underlying OSA. As part of the evaluation at some point, one should include pulmonary function testing, again based on the same reasoning that a large percentage of patients with underlying allergic rhinitis also may have a component of asthma. What about considerations for differential diagnosis? One of the more common things we see is underlying nasal polyposis. These patients have significant congestion. They will frequently report a loss in their sense of smell, and that's frequently a clue that there's more than just underlying allergic rhinitis present. Deviated septum causing a mechanical problem. Again, this is a frequent occurrence in many patients, so it needs to be significant in nature. Adenoidal hypertrophy, particularly in children. Trauma, foreign bodies, again more common in children. Nasal tumors, more common in adults. Conal atresia, cleft palate. Cerebrospinal fluid or CSF leak. Trauma can sometimes be an underlying clue there. Unilateral rhinorrhea that's profuse, clear, associated with headache. And then ciliary dyskinesia syndromes. Many of these patients also have history of underlying pneumonias or lower respiratory tract infections. Now we'll show you a video of a patient. So here we have a typical patient we all see. Let's summarize her history. No current diagnosis of allergic rhinitis. Nasal symptoms over the past several years, so that's important. There's chronicity to this. History of otitis media, therefore comorbidities exist. She's had previous course of antibiotics for suspected sinusitis. She's allergic to penicillin, and she's never been allergy tested. Her current medications include over-the-counter antihistamines, cold medications. Despite these, she's still very symptomatic. Nasal sprays in the form of saline and oxymetazoline, so there's potentially overuse of topical decongestants here, and limited success with this regimen. Persistent nasal symptoms that have become more severe in spring and fall for her. Nasal congestion that was severe enough to cause her to breathe through her mouth. In children, this becomes very important, as it may affect their facial morphology as they grow, becoming obligate mouth breathers. Pressure in sinuses and behind the ears, and then nasal irritation, discharge, pruritus, and congestion. What about physical exam? Her HENT exam was abnormal for the nares. She had septum that was midline but swollen, red, nasal turbinates, pale mucosa with mucus obstruction and production. Sinus tenderness was noted with increased drainage. However, no polyps were appreciated. Throat exam revealed a clear oropharynx. Skin exam, color, texture, turgor were normal. Her nasal symptom severity score was 5, and she had positive prick skin tests for cat dander, dust mite, so those are perennial allergens, and then timothy grass and ragweed for seasonal sensitivity. So diagnosis in this patient would be moderate to severe PAR with seasonal increase in symptoms, and this is corroborated by her skin testing, possible underlying sinusitis. So pharmacotherapy, one option would be intranasal steroids. However, one may have additional considerations for treatment. There's no one correct answer or one correct starting point here. What would one recommend regarding electrostatic filters? This is a question we get commonly asked. When you look at the data, there isn't much data justifying or corroborating the use of electrostatic filters. The one caveat to that is animal dander allergy. In the case of animal dander allergy, there are some studies using Centra HEPA filtration to improve underlying environmental exposure. There's also been some theoretical concern with ozone-producing filters in those who also have underlying asthma. Would you advise the patient to place mattresses in polybag? Well, yes, if they're in a dust mite endemic area and they're dust mite allergic, as is this patient. Is it valuable for patient to keep their windows and doors closed during pollen season? We always recommend that to minimize air exchange with the outside, particularly on high pollen count days. So how would we advise the patient to manage the cat in the home? Well, there's really good data showing that if we wash the cat once a week, that really reduces the allergen exposure, but that's not very pragmatic. Another recommendation that is more practical that we give is to at least keep the pet out of the bedroom, to at least minimize the lengthy exposure one would have during overnight sleep. We should also schedule a follow-up visit for 2 weeks out to assess the resolution and symptoms. This improves adherence, or we can adjust therapy accordingly if still not achieving adequate control. Well, let's transition to discussing the evidence to promote early recognition and treatment of AR. The respiratory tract is considered an integrated system by which local inflammatory processes and systemic mediators promote reactions throughout the air space. So we frequently state that the respiratory tract begins at the tip of the nose down to the bottom of the lung. And this is also frequently referred to the one airway hypothesis or the universal airway theory. Here in this cartoon, you see potential explanations or hypotheses of this connection. For example, there may be local neural reflexes that may be mediating this connection. When the upper respiratory tract gets inflamed, you see an impact on the lower airway in the form of either bronchial hyperreactivity or true-out asthma symptoms. There may be an allergen component to this. Some of the allergens deposit in the upper respiratory tract, but examples such as cat, they may go down to less than 2.5 microns, and that's a respirable size, and therefore they impact both upper and lower respiratory tree. Then there's the systemic mediator theory, which I think is the most plausible, and that is that there are systemic production of eosinophils and pro-allergic factors that cause cells to chemotax to the airway, and their local chemotactic factors then drive the inflammatory cells both to the nose and the lung. And one measurement that we see that may support this is that many of these patients also have increased circulating eosinophil levels in their peripheral blood, which would not be very well explained by a local neural reflex theory. However, further research is needed to delineate the exact mechanism underlying this connection. Evidence supporting the unified airway model are the following. Allergic rhinitis and asthma can occur at any time in a person's life, but AR usually precedes the asthma in a large percentage of patients. Approximately 20% of patients with AR and probably up to 40% of patients actually report asthma as a comorbidity. So we always stress, if you're seeing a new patient that comes in and says, my allergies are bothering me, they may not clue you into the fact that they're also having lower respiratory tract symptoms, but up to 40% of those patients may also have some underlying lower respiratory dysfunction. The presence of AR increases the risk 3 to 4-fold during the 20s, the risk of asthma that is, and approximately 40% of non-asthmatic patients with AR have increased bronchial hyperreactivity at a minimum. When we look at it the other way, those that have asthma, up to 80% of those patients may have associated allergic rhinitis. These are data that support what I just stated. What we see here from the Allergies in America survey is in the yellow are those patients that were diagnosed with asthma. In the dashed bars, we see asthma symptoms in the past 12 months. On the left side are the adults. On the right side are children with AR. And again, you see up to 40% of those diagnosed with asthma of the total respondents also had underlying AR. What about environmental control and patient education? We need to identify the triggers when possible that can help us tailor therapy. Implement avoidance measures when practical, such as washing the cat every week is not overly practical, but keeping windows and doors shut on high pollen days is very doable. Outdoor activities are best after rain since there's been a washout of the high ambient pollen count. Control the environment, dampness, mold, cockroach, for example, irritant avoidance. But we ultimately need to judge success by clinical parameters, and that is a reduction in patient symptoms and medication scores. So how do you advise your patient to control pollen, dust, and animals? Well, here are some strategies. Limit exposure, limit the exposure and confine it to uncarpeted rooms. Keep them out of the bedroom in the case of pets. Wash the pet, as I've mentioned several times. Replace the carpet with hard surface flooring. This minimizes dust mite reservoir. Remove fabric, upholstered furniture, again reducing a dust mite reservoir. Remove the pet from the home is the ultimate strategy, but we need to be sensitive to the role of that pet in the family. Wash the linens in very hot water. That minimizes dust mite allergen. Change of clothing after a high allergen exposure, and potentially use vacuums with HEPA filtration. So now let's talk about pharmacotherapy. Again, looking at data from Allergies in America, if we look at the common symptoms that are reported by patients, one thing you always see falling out is nasal congestion or stuffed up nose, as was queried in the survey. You see 22% reporting nasal congestion. And then the other common symptoms being headache, postnasal drip, red itchy eyes, runny nose, and then it falls off to generic itching, facial pain. If we look at patient-rated troublesome symptoms of nasal allergies in the last week, so now looking at the short term, the question was, how troubled have you been by these symptoms during the last week? Were you not at all troubled, hardly troubled, somewhat troubled, or moderately troubled, or extremely troubled? Once again, you see sneezing and nasal congestion or stuffy nose falling out as the most prevalent. Here's the pharmacopoeia for allergic rhinitis: intranasal steroids, intranasal antihistamines, oral antihistamines, which are now available over the counter, oral leukotriene antagonist, and then we have oral corticosteroids, which obviously are not preferred due to side effects unless absolutely necessary, nasal saline, which we use significantly or a lot of in patients in National Jewish, intranasal cromolyn, which has fallen by the wayside to some degree. There's the intranasal anticholinergics, which are approved really only for rhinorrhea, not for the other symptoms that we see reported in AR, such as congestion. And then there are oral and topical decongestants. The oral antihistamines have been the mainstay for allergic rhinitis. They've been around since the 1950s. They reduce rhinorrhea, pruritus, and sneezing. They're generally considered ineffective for nasal congestion unless they're combined with an oral decongestant, so the drug is the antihistamine D formulation. They have a rapid onset of action, which, depending on the study, has been reported anywhere from 30 minutes to 3 hours, depending on how the trial was conducted. The second-generation antihistamines have less anticholinergic, antiserotonergic side effects than the first generation. The intranasal antihistamines, on the other hand, if you look at the U.S. allergic rhinitis guidelines, Dana Wallace was the first author, and you see the reference here. They state that the intranasal antihistamines are recommended as potential first-line treatment for AR. The intranasal antihistamines are also interesting in that they're associated with a clinically significant effect on nasal congestion in most of the studies. That's different than the orals, where you have to actually combine an oral decongestant. So here, possibly the direct delivery to the nasal mucosa is providing a different type of bioavailability and giving you a decongestant effect. They also reduce rhinorrhea, pruritus, sneezing. They have a clinically significant rapid onset of action, and in some studies as early as 15 minutes. The onset of action is really determined by when you make your first time point measurement. So if the trial made the first measurement at 30 minutes and there was efficacy, then it would be a 30-minute claim. They're equal to or superior to second-generation oral antihistamines, again according to the guidelines that reviewed the data. They may provide added benefit when used in combination with intranasal corticosteroids. And now, actually, there's an approved product that shows synergistic effect. But they may have bitter taste, and in some cases very significant so, and sedation in some individuals. If we look here, seasonal allergic rhinitis symptom reduction over 2 weeks with olopatadine, which is one of the two intranasal antihistamines, we see the total nasal symptom scores on the left, and this is a very typical outcome in the development of allergic rhinitis medications. And then you see the individual domains: nasal congestion, rhinorrhea, itchy nose. And as one would expect, they all reach significance over placebo, or the medication would not be approved or be on the market. Here you see the other intranasal antihistamine, the azolastine, and that has had several formulations over the year. So in the different colors you see, for example, in the yellow or yellowish, you see azolastine 0.1%, and then it was reformulated to a sucralose sorbitol base, and that was the azolastine 0.15%. Nevertheless, if we look at the individual domains of the TNSS, we see significance for the two active drugs relative to placebo. Again, on the y-axis, it's mean change from baseline. This is a very standard trial design for the development of AR medications. What about the LTRAs? They're less effective than intranasal steroids in most trials that have a head-to-head comparator. They're not more effective than antihistamines. They target leukotriene C4, D4, and E4 receptor to improve nasal congestion. The 10 milligram dose, for example, of montelukast improves symptoms in some of the Merck publications up to 86.5% of patients. There's marked improvement in QOL in 82% of patients. Sleepiness is similar to placebo in AR, and it was approved in the US for asthma and then later for seasonal and perennial allergic rhinitis. The intranasal corticosteroids, they are the most effective class of drug for the treatment of underlying allergic rhinitis, and that's due to its anti-inflammatory mechanism of action. They're efficacious for rhinorrhea, itching, sneezing, and nasal congestion. And in some trials, they reduce nasal polyp burden. They help with chronic rhinosinusitis and allergic rhinoconjunctivitis. However, it's important to state that they don't actually have a true sinusitis indication. Actually, no medication has a true chronic sinusitis indication. Intranasal steroids are superior to antihistamines in reducing inflammation and nasal congestion, which can result in decreased sleep disturbance, as we saw earlier in some of the epidemiologic data, and loss of productivity. Intranasal steroids have been shown to be more effective than the combined use of an antihistamine with an LTRA for the treatment of SAR. This is one of the commonly cited meta-analyses that was performed. And those of you who may not be accustomed to seeing this, anything that crosses the zero line in the middle is a trial that did not show significance in one direction or the other. However, if it's skewed to the left, that favors the intranasal steroid. If it's skewed to the right, it favors the oral antihistamine. This meta-analysis looked exactly at that, the intranasal steroids versus the oral antihistamines. And the studies are listed on the left. The outcome measure was total nasal symptom scores, and then you see the composite at the bottom in the grayish color, and you see that it's on the left side, not crossing zero, and therefore favoring the intranasal steroid. If we look at the same sort of analyses for intranasal steroids versus intranasal antihistamines, again, if we look at the composite score at the bottom in the gray with the same outcome measure, that being total nasal symptom scores, we see that it was in the favor of the intranasal steroid. These are the aqueous intranasal steroids that are currently available on the market: fluticasone propionate, flunisolide, triamcinolone. I won't read them all. You can see them. You can see their formulation, the adult dosing, the pediatric dosing, their pregnancy category. Budesonide's the only one that has a pregnancy category B. Some of this was based on the fact that they had large Swedish database of pregnant women, and therefore they were able to obtain a higher rating. Most likely they all behave the same, or it's a class effect, but nevertheless it's important to know that budesonide has a rating B. There are two new aerosolized or non-aqueous intranasal steroids now in the market, similar to some we had in years gone by. The first is beclomethasone dipropionate, comes as 80 micrograms per spray, 2 sprays per nostril daily, pregnancy category C. The other that's been approved is the cyclesinide HFA, comes as 37 micrograms, 1 spray per nostril daily. Again, similar pregnancy category. Here now we'll see a second patient. So summarizing this patient, we have a 16-year-old male, current diagnosis of perennial allergic rhinitis with moderate symptoms. And this patient also has what sounds like intermittent asthma. Patient's never been allergy tested. Current medications include intranasal antihistamines, 1 spray per nostril twice a day, and short-acting beta agonists, and before gym class or with symptoms outside of exercise. And in this case, there's been increased use of the short-acting beta agonists. Physical exam, blood pressure's fine, HENT exam, swollen red turbinates, postnasal drip, nasal discharge, watery itchy eyes, and allergic shiners. Skin exam was unremarkable. However, on respiratory exam, patient had wheezing on expiration. The asthma control test, or ACT, revealed a score of 14. The patient also had daily nasal and ocular symptoms that worsened during allergy season. In the last 3 months, the patients needed albuterol rescue every other day, which really only provides temporary relief. The patient's fatigued during the day, has 1 to 2 nighttime awakenings per week, experiences bronchospasm with exercise, and productivity has been lower at school, and the patient's not tolerating current intranasal therapy in the form of the antihistamine spray. So the diagnosis in this patient at a minimum would be perennial allergic rhinitis with moderate to severe symptoms and with seasonal exacerbations. It's also important to realize this is the one airway patient. He also has involvement of the lower respiratory tract, and based on his FEV1, it falls into the moderate persistent category. Treatment would include potentially intranasal steroid with a medium dose inhaled corticosteroid for his underlying asthma. The patient can continue to use a short-acting beta agonist and intranasal antihistamine as needed. We need to provide patient education on allergic symptoms as well as controlling and treating the asthma. Potentially consider referring to a specialist for evaluation of underlying allergic triggers by skin testing. And it's very important to schedule a follow-up visit in 4 weeks to review the allergic triggers, the effectiveness of the treatment plan, as well as control of the underlying asthma. Let's transition now to tolerability of medications and patient preferences. If we look at the overview of intranasal steroid safety and tolerability concerns, there really is minimal to no systemic absorption when taken at the usual recommended doses. There's low risk of epistaxis, although depending on the study, the way the epistaxis was defined, you see it reported anywhere from 5 to 20%. There may be local side effects that are typical, such as burning, stinging, or dryness, but the more rare would include potentially nasal perforation. We see it rarely. Frequently, when you do see a perforation, there may be another explanation, such as a post-surgical defect, potentially prior drug use, and also extremely rare is HPA axis suppression. Reasons patients ask their healthcare providers to change their medications. 57% said it was not effective. However, a very small percentage, 6%, said effectiveness began wearing off after time. So many of these new medications do truly last up to 24 hours. Negative attributes reported in patients who use nasal sprays, most of those are sensory. In 86% of patients, there were sensory side effects such as aftertaste, odor, potentially nasal irritation. Throat irritation was reported by 84%. Spray runoff down the nose or throat reported by 71%. And in the nasal survey, which if you remember is the 2010 survey, 1 of 3 patients, or 33%, who have used a nasal steroid spray in the last year named dripping down the throat as moderately or extremely bothersome side effect. If we look at dripping, feeling, and discomfort associated with dissatisfaction with the intranasal sprays, in the blue you see always, most of the time, or some of the time, and in the red rarely or never. Of those that experienced a significant amount of dripping or feeling or that sensation of dripping, they were less satisfied than patients who had less of that side effect. Now let's look at the aerosolized formulations, which are new on the market, of the intranasal steroids. Is there a role for aerosolized intranasal steroids in AR management? Well, evidence suggests that patients choose whether or not to take their medications based on sensory characteristics. Why patients may prefer an aerosolized over an aqueous? Well, that may include the device, the ease of use, the lack of odor or drip, as we've just mentioned, or lack of bad taste, no anterior and posterior runoff leading to throat irritation or pharyngitis, and less of a drippy sensation, which frequently is an issue in those that have chronic rhinitis. And the converse, why patients may prefer an aqueous formulation. They have familiarity with the device. We've been using them for 2 decades, they may find it soothing, particularly in dry climates. They have established safety and efficacy, and there's a wide variety of available options. What about potential benefits of aerosolized delivery? Polyps, distribution of the spray may have a better impact on the nasal polyps. Olfactory disorder, again, distribution of spray may be the mechanism that gives us better efficacy. Pre-surgery, post-surgery, or in children or adolescents where the feel or the spray volume, in the case of a liquid, is a negative attribute. If you have a wet AR patient, they may like that drying effect. They've previously failed an aqueous product, or they're bothered by the side effects or can't tolerate the aqueous product. Well, let's look at the 2 new aerosolized products in the market briefly. Obviously, I can't show you all the data, but we'll show you some. First is the cyclosinide HFA, which is approved for the treatment of SAR. This is a randomized, double-blind, placebo-controlled trial, very standard design, 707 patients greater than 12 years of age with seasonal allergic rhinitis. The cyclosinide HFA was delivered as either 80 micrograms or 160 micrograms once in the AM for 2 weeks. Improvement was shown in the reflective total nasal symptom score as well as the instantaneous. So this is very standard in allergic rhinitis trial design to measure both the reflective, which is the symptom score that's measured over a predefined time period, and then the instantaneous is measured at the end of the dosing period, and in many ways it's more important because some drugs lose effect over time, and so if you measure the score at the end of the 24-hour period, you get a better gauge of the duration of efficacy. All individual nasal symptom scores were significantly improved. Here you see the data. In the yellow is a cyclosinide 74 micrograms, and in the red is a cyclosinide 148 microgram. You see the data over time periods. In all cases, relative to placebo, there was significance. Here are the side effects. The left column has the low-dose cyclosinide, the middle column the higher dose, and placebo on the right. And you see that they're not much different from an adverse standpoint relative to the placebo cohort. I'll just leave that up for a moment and let you take a quick look. How about the other new aerosolized HFA, the beclomethasone dipropionate HFA for the treatment of SAR? This was also a randomized, double-blind, placebo-controlled trial of 340 patients greater than 12 years of age. The BDP-HFA was given once daily for 2 weeks. That's a standard duration for these studies. And there was improvement in total nasal symptom scores over placebo. There was also improvement in ocular symptom score that was significantly greater than placebo. The individual nasal and ocular symptom scores also significantly improved. And this was evident as early as day 2. Here you see both data again. On the left is the reflective TNSS, on the right is the instantaneous. And if you hit significance on your instantaneous, your reflective is also going to reach significance. On the y-axis is a change from baseline, very standard. In all the individual domains of the TNSS, congestion, itching, rhinorrhea, and sneezing, you see improvement over placebo, both in the reflective and the instantaneous. Here again, you see the side effects. On the left is the BDP-HFA, on the right is placebo, and it looks relatively similar between the 2 arms. What about satisfaction with ease of use of aerosol nasal devices versus other nasal sprays? If we look at Gary Gross's abstract here, and what we see is in the yellow, somewhat satisfied or very satisfied, and in the red, neither satisfied or unsatisfied, and then in the blue, they're not satisfied at all. The majority of patients were very satisfied or somewhat satisfied, as noted in the yellow bar. The current guidelines recommendations, this is again the U.S. Allergic Rhinitis Guidelines with Dana Wallace as the first author. When we look at their recommendations regarding INSs as first-line treatment, the following statements are made. It is the most effective class for continuous symptoms treatment of AR, effective for the treatment of nasal congestion, rhinorrhea, itching, and sneezing, again the components of the TNSS. They're recommended for continuous use. They're more effective than antihistamines in reducing inflammation and nasal congestion, and they're more effective than the combined use of an antihistamine and a leukotriene receptor antagonist, as I mentioned previously. Patient education. The guidelines recommendations regarding patient education are as follows. We need to educate the patient and caregivers. That's a key to promoting adherence and optimizing success with our treatments. The education may include avoidance measures, environmental precautions, addressing the chronicity of the rhinitis, institution of these control measures, helping them implement and operationalize that, the benefits of the medications, discussing the side effects so they have realistic expectations. That all improves adherence. And then there's also the availability of allergen immunotherapy as an option if they fail pharmacotherapy. The guidelines, recommendations regarding encouraging compliance, potentially consider a written action plan, or at a minimum, write out their medications and how appropriately to take them and how frequently. The treatment plan that's developed should be developed jointly with the patient, the family, so it's a group effort. Take into the account school, work schedules, therefore again improving adherence. The patient preference, do they like dry versus liquid versus pill? Realistic goals for environmental modification. What to do in the event of increased symptoms, and a long-term management strategy for the chronicity of their symptoms. So in summary, strategies for improved care should include patients with AR should be evaluated for asthma due to the underlying airway connection and the increased incidence of disease in the counterpart of the respiratory tree. So if you have rhinitis, the presence of asthma. If you have asthma, the presence of rhinitis. The goals of therapy is really to reduce symptoms of AR by controlling the underlying inflammation in both the upper and lower respiratory tract. Therapy should be chosen and weighed according to symptoms, the frequency of those symptoms, the treatment effectiveness, what the patients tried, what they haven't, what have they failed, the safety of the medications, and patient preference to the sensory attributes. INSs are the most effective class of drug for the treatment of AR, and patient education and planning is a critical part of the management. I want to thank you for participating in this program today. I also would like to thank National Jewish Health, Integrity, and Teva Respiratory for supporting this program.